Hello everybody, I'm Victor Zarev here with Cardiac Wire, and today we're going to be interviewing Dr. Joshua Lampert a little bit about AI's trajectory in clinical practice. So why don't you go ahead and tell us a little bit about yourself, Dr. Lampert.
Sure, well, thanks for having me. I'm Josh Lampert. I'm a cardiac electrophysiologist, and I'm the medical director of machine learning for the Mount Sinai Fuster Heart Hospital at Mount Sinai in New York City.
Wonderful. So we've seen AI mature a lot over the last few years into a lot of modalities, especially in the cardiac space. Could you tell me a little bit about some of the challenges that these early implementers might face as AI becomes more and more part of a daily practice?
Sure, so it's actually a really excellent question. So, we have a multitude of different algorithms that are starting to come to market, but one of the big challenges is really in the implementation science. And for example, in clinical teams, knowing what model predictions mean, how they should be able to counsel patients based on the results, and to really implement that into meaningful clinical workflows that essentially would allow for efficient but also safe patient care.
Could you give me an example of what one of those implementations would look like or calibrations?
Sure. So we actually had a paper recently come out at NEJMAI where we kind of highlight the role of model calibration. And so essentially what that is models are happy to make classifications and cluster predictions around 0 and 100%. So the actual number that a model may give you doesn't actually mean anything. It'll give you your binary classification, high risk, low risk. But for what that means for a patient, what that means for a clinician to be able to counsel that patient is actually pretty challenging. And so the way that we can address that issue is by calibrating the model, which there are multiple ways of doing that. We used a simple logistic regression flat scaling to essentially spread those probabilities over the scale of the actual probabilities. So essentially what that means is that you can suggest to a patient that you have approximately 60% likelihood of having a disease. For this recent study, we used hypertrophic cardiomyopathy. So it gives a lot of granularity and interpretability, not just for the clinicians, but also for patient teams. We also suggested a pragmatic approach to the clinical workflow where whenever you start operating these things at scale, you're going to have work lists of patients that are flagged as high likelihood for the disease of interest. And you need a way to be able to triage them for care. And so you can actually sort patients by these probability scores so that you can actually bring all of your true highest risk patients right up to the top of your work list.
So that's really interesting. Essentially what you're doing is cutting out the noise and making it more efficient and being able to really figure out who are the people who should be addressed first with the
Exactly. We do suggest that whenever models are approved, there's a baseline classification threshold that's agreed upon based on sensitivities and specificities and the expected impact on patients. And so we're not suggesting that you ignore patients that filter out by this method, but what we are suggesting is that this can be a pragmatic tool for implementation so that you can focus attention immediately and expedite care for the highest risk patients.
Wonderful. Moving forward, what are your thoughts on, how is this going to have interplay as people understand how to better calibrate these products and implement AI? What's kind of your forward-looking insight on that?
I think looking forward, as we start to have more models come onto the market and also have it really be incorporated into the whole of clinical care, we do need to do a little bit of education so that clinical teams understand what these models are going to mean, what they're going to mean for their patients, because at the end of the day, our duty is to our patients and we need to be able to counsel them on what any result means for them, whether it's an echocardiogram or an EP study or an AI model's prediction, right? And then on top of that, we're really going to need to focus more on the implementation science on how we responsibly implement these tools into real clinical practice in a meaningful way that ensures efficient patient care and safety.
Wonderful. Well, thank you so much for your time today, Dr. Lampert. We sure learned a lot, and thanks for watching, everybody.